There we go. So once again, welcome to our Digital Health Week event. This event is being co-hosted by BC Children's Hospital Research Institute and the Women's Health Research Institute. Before we get going, I want to acknowledge with gratitude that our research institutes are located on the traditional, ancestral, and unceded territories of the Coast Salish peoples, specifically the Musqueam, Squamish, and Tsleil-Waututh nations. I want to also acknowledge that I live and work when I'm at home, as I am right now, on the unceded territory of the Sechelt Nation. And I know many of you are joining from across the province, as this is a virtual event. And so I encourage you to take a moment to acknowledge the lands which you live on. The First Nations have nurtured and cared for these lands and waters around us for all time. And we are very grateful to have the opportunity to live and work in this beautiful place. And with that, I just want to mention that our event is part of a series of events that are being hosted. Hopefully you've all participated in some of the other amazing talks that have happened this week. There's more tomorrow as well. And so we'll put in the chat and a note about how you can get access to the full PHSA agenda. And this year, the theme for Digital Health Week overall is empowerment, equity, and inclusion. And I think those are really critical words related to digital health that I hope that we'll all reflect on as we hear the speakers talk today, because there's much promise around digital health to achieve these things in healthcare, to bring greater equity in healthcare from increased access to care, better quality of care, and to be designed in a way that includes everyone. And with that in mind, I just wanted to mention one other initiative that is going on in our research institutes. We mentioned the inclusive design that is critical to digital health, and so BCCHR and the WHRI are partnering in developing a shared research agenda for digital innovation to support perinatal health care. And part of developing this research agenda is engaging those people who are most impacted by the digital transformation. And that includes patients, but also care providers. So we have a series of engagement activities we're planning. The first one that we're launching is listed here. We're going to be hosting a thought exchange that's now live. So this is open to any healthcare provider, nurse, allied healthcare, physician who's involved in perinatal healthcare in the province. We really want to hear from those of you who are providing care, your thoughts on what's valuable around digital health to you currently, but also what you feel is needed to move us forward in care in the province, so that we can address research goals to meet those needs. So there's a QR code there. If you are a perinatal healthcare provider, I encourage you to participate in the thought exchange. You'll be seeing this hopefully in many other ways over the next few weeks, so there'll be other opportunity to participate. I just wanted to mention it here.
Beth, is it okay if you go back to the previous slide and then reshare your screen? We can see the speaker presentation mode. So some people are having difficulty reading the details on the past slide.
That's funny. I must have switched my screens. Hold on. Let me share again. Thank you for telling me. Let's see if we can do this again. What do you see now?
I still see the presentation speaker mode. There we go. Yeah, can you go on the previous slide so people can maybe take a screenshot or scan the QR code?
Thanks, Jetha. It's very slow. There we go. So there is the QR code. and we look forward to your participation if you are eligible for this. I'll give you a minute. Okay, I don't want to take up too much more time because we have a lot of exciting speakers. And so just to take a moment again, we did have to switch to fully virtual, and I appreciate you all attending in this mode and quickly reorganizing. So we will be having at the end of our speaker series an opportunity for the vendors and our partners that we had invited to be in person to give a few comments about the work that they're doing. So we've extended this, and we hope that you can all stay to the end. But without further ado, I want to welcome our first speaker, who will be Tania C. And Tania is the winner of this year's Best Trainee Poster Prize Award. So in parallel to this event, we do have a virtual poster presentation series that's on YouTube. But if you go to this QR code, we'll also put the link in the chat. You can watch these poster presentations anytime throughout the week, and they'll be up for the next couple weeks. And so you can learn about the great work of the trainees at various academic institutes around the province in digital health. And with that, I'm going to stop sharing, and I'll hand the floor over to Tania to give her first presentation.
Hello. Hi, everybody. I'm Tania. I'm a second-year MPH student from SFU. Today, I'm so pleased and honored to present my work at the practicum students at Dr. Meereen's office. The project title is Evaluations of Mobile Applications for Collecting Postpartum Patients' Report Outcomes Measures After Cesarean Delivery. And the aim of this project is to test the usability and acceptability of the mobile app called CCare2. Postpartum maternal morbidity is common after cesarean delivery, and there is currently no simple and effective method for routine longitudinal follow-up. Effective data collections from postpartum patients is an important first step to help understand or tracking their recovery and to guide research in developing interventions to improve perioperative patients' outcomes and experience. However, new mothers often face unique challenges that may discourage them from research participations and healthcare access. For example, they are lack of time or have scheduling difficulties, and they are heavily engaged in taking care of the newborn baby. We also received feedback from patients' partners that due to the sensitive natures of postpartum experience, they may feel more comfortable filling out the questionnaires with a privacy setting, such as using mobile app, rather than through a stranger during the public health nurse visit. Therefore, it comes to our research questions that is there any patient-centered scalable tool to capture patients' report outcomes and allow routine longitudinal follow-up of postpartum recovery? Our team has designed a mobile application called CCare2, which is built on a ready-to-use digital health platform known as Cambion. The Cambion platform already contains functionalities for longitudinal questionnaires delivery and meets security and privacy regulations. Currently, 3 validated questionnaires are included in the app. Additional features such as information for useful resources and patients' educations will be continuously built to the app in the future. Our team is recruiting patients to take part in a larger prospective longitudinal cohort studies, which target around 130 patients participants. Each participant will complete a personal information questionnaire at the beginning and 3 validated questionnaires at various time points using the app. The 3 questionnaires include the WHO Quality of Life, the Edinburgh Postnatal Depression Scale questionnaires, and the short-form brief pain inventory questionnaires. The larger core studies will focus on the feasibility of the app, the characterizations of geographic and ethnic distributions of the participants, and to study preliminary results of the patient's report outcomes measures. On the other hand, this usability study is a sub-study of this large project, which aims to explore the usability and acceptability of the app in a real-world setting. This is to focus mainly on the perceptions from the patients and healthcare workers towards the app. In our studies, efforts will be made to recruit culturally, economically, and geographically diverse participants within BC. The usability studies will identify patients participants who are already in the larger study. We will approach them for these studies using email and phone calls starting from at least 8 weeks postpartum. In this summer, we conduct a literature review on existing postpartum mobile apps to inform designs of the usability protocol. The usability testing consists of 3 cycles, and each cycle has 3 main parts. It is the interviews with postpartum patients, having app users complete the system usability scale survey, the SUS survey, and the focus groups with the healthcare workers. For the interview, each cycle will include at least 5 patients. Given the participants will be recruited across BC, we plan to hold one-on-one semi-structured interviews virtually using Zoom. Also, before the interview, there will be requests to complete the SUS survey. In short, the SUS survey is a 10-item Likert scale, which is typically administered immediately after interactions with the app to allow users to record their initial feelings and responses. Both interview and the SUS survey will be conducted starting from at least 12 weeks postpartum. Finally, we will hold at least 1 focus group discussions with at least 5 healthcare professionals per cycle. In view of their busy schedule, focus group will also be held virtually. This study is currently ongoing. We pilot test the interview guides via Zoom with 1 patient's pilot as well as researchers in the team. Preliminary codes have been identified that will be used as an analysis framework for future interviews. We believe that feedback from patients about the experience using their mobile app and comments from healthcare workers will provide information on the acceptability and usability of the CCare2 app. Data collect will inform and support modifications of the app before full-scale implementation. It will also inform priority conditions and areas for patients' educations and follow-up care in the postpartum period. That's all for my presentation. Thank you.
That was a lot of information for 5 minutes. Thank you so much, Tania, and congratulations once again on that incredible work. We'll be really excited to see the results of some of the work and where the app ends up after all the usability cycles. Just for curiosity, what is the timeline for this study? Where are you guys at with the cycles and the development work?
For the larger cohort study, the timeline should be next year end. And therefore for this small study, it should be more a similar time.
So maybe next year we'll get to hear some of the results.
Yes.
Yeah. Thank you once again. And once again, Tania is the winner of this year's Best Poster Prize for trainees. If you want to go watch the virtual poster presentations, there's a link in the chat to the YouTube channel. You can go at your leisure and watch them. There's some great work happening across the province at the various academic institutions.
The other presentations were also very, very good.
Yeah. Yeah, it was a stiff competition this year. So with that, we're going to move into our main talks for the day. We're starting out with May Tuason. May is the Director of Clinical Architecture and Innovation at the Digital Health Strategy Office in the Ministry of Health and PHSA. May is a registered nurse and highly skilled digital health leader with over 20 years of work experience in private and public sectors in Canada and the US. Currently, May is the Provincial Program Director for the IMS-BC COVID-19 Vaccine Management Digital Platform. This has been responsible for the registration and communication about vaccine access to more than 4.5 million eligible citizens in BC. So I'm sure we can learn a lot from the experience of this digital health platform rollout. May holds a master's degree in business administration from the University of Liverpool, as well as her degree in nursing from UBC. She's a certified professional in information management systems and a project management professional, and has several other credentials, which I'll leave off for now. But May, if you'd like to go ahead and share your screen and take it away.
Thanks so much, Beth, and congratulations again, Tania. It's great to share the panel with you today. Our future is so bright with you and everyone here that we're sharing our time together today. So congratulations again. I'm just going to share my screen quickly and then let me know if you're able to see the title page, IMS-BC. All good?
There's just the speaker notes are in front of it for some reason for me.
Okay, let me see if I can try this again. Oh, I
Seems to be the theme having.
let me try one more time.
There, that looks
Much
great.
better? Okay, wonderful. All right. So as Beth mentioned today, I'm fortunate to share with you BC's story of the COVID-19 vaccine program and digital solutions on behalf of all the teams who played a role in our public health solutions over the last 2 years. Today, I am specifically addressing a program that was used by more than 80% of the population and vaccine providers accessing this solution over the last 2 years. It's the Get Vaccinated website and again, the IMSS-BC vaccine management solution. I have nothing to disclose. And I'd also love to acknowledge all of the work that you and our healthcare workers have done to keep BC healthcare open during these unprecedented times. So thank you again for everything. And I know we all continue to recover. There are great mental health resources here in BC that I know have helped myself and my family as well. And so with that, you know, this is a very familiar scene, isn't it? Every time Dr. Bonnie Henry and Minister Adrian Dix took the podium to guide people in BC through the pandemic, a dedicated team of leaders, clinicians, service agents, writers, communicators, designers, technologists, and volunteers stood behind them to help the people follow public health orders and stay safe. The story of BC's success in the face of the pandemic is a testament about the power of teamwork around people-centered goals through a global emergency. Together, through tight coordination between national, provincial, regional leadership, operations, communications, and digital solutions, we addressed key challenges from reaching at-risk remote and Indigenous communities, managing inventory and supply distribution all around the province, to standing up and managing capacity of vaccine clinics, large and small, urban to remote, across our regional health authorities, and then later with our pharmacy partners across almost 1,100 local pharmacies. Expertise across sectors at joint tables all reported up to Dr. Henry, Minister Dix, and Dr. Penny Ballum. So clear leadership and strong governance were absolutely key. Actually, after this webinar with you, I'll be running over to the coordination committee actually with Penny, the health authorities, the pharmacies, and everyone there, so that we can continue to keep all of our work streams aligned during the COVID and influenza campaigns this year. And as you all recall, the stakes were high. Provincial health orders stalled whole industries and asked people to stay away from work, from travel, and their loved ones. People needed information in the simplest terms to help flatten the curve in a way that met their needs. It seemed like, we used every medium possible for maximum reach. The pandemic, in a way, ushered the age of omni-channel healthcare. No matter which way a patient accessed information or health, consistent information would be offered through video conferencing between patients and providers, online chatbots, press conferencing, live streaming, social media posts with over 300 million views, plain language summaries with over 220 million views, news media releases, contact centers actually with live agents on the other end for those citizens that would prefer to call and talk to someone live as opposed to accessing online information. And then we also went on to telephone and video town halls, connecting people to their local leadership. And then later on in the campaign, introduced TV, radio, and movie theater ads. So creating this quality information was complex. Information was made available in 12 languages, American Sign Language being made available during live stream conferences. And much of this work was actually led by our government communications and public engagement teams in collaboration with our regional health authority communications teams too. All throughout, our goal was to keep the message positive and consistent, encouraging people to use good judgment and do the right thing in extraordinary times. Like, as you can see, that's my niece right there in the center. She recorded a message to her friends, letting them know, that the vaccine just felt like it was just a little pinch. So after coming back from the vaccine clinic, she reported back to me and she said, You know, those stickers, Auntie, those were well worth the wait and worth that pinch. So that was really great to hear, you know, directly from the actual citizens about how, you know, how some of these clinics were run and how they met the needs of our youngins there. So that was great. The news of the COVID-19 vaccine's arrival, though, came in absence of any system or any service capable of vaccinating over 4.5 million people, twice over, and then with a booster within an 18-month period. So we started off with an online form in the early days to document immunizations with healthcare workers, but we knew we needed a much larger, a system much larger for managing and engaging people. You know, we actually saw at the height of the campaign about 65,000 people a week, and the system had to be simple and flexible enough to prioritize and be accessible to our most vulnerable people. Public servants and private sector partners worked day and night to get to build the Get Vaccinated system, to register and book vaccinations, which is the website you see here on the screen. People could go online and register expressing interest in the vaccine. The provincial call was stood up at the height of the campaign. Agents were handling up to 70,000 calls a week. 6 regional call centers were centralized to a provincial call center in just over 7 days. So it was quite a hectic time 2 years ago. Health authority and pharmacy providers use the IMSBC digital solution to manage reminders, notifications, appointment scheduling, inventory, and real-time data. And this data was just really critical for us to be able to measure our expected outcomes. And really huge kudos and great acknowledgements to our provincial reporting and analytics teams, our regional decision support teams. There was as you all recall, a major scrutiny about the progress of our campaign. It took us only 9 weeks to go from product goals on a virtual whiteboard to a minimum viable product in a live environment. We did follow agile methodology and the Scrum framework to release new features and enhancements every 2 weeks based on data used from user experience, technical operational data, population health data, and evolving policies of the COVID campaign. Change management support and training were completed for almost 25,000 users through our amazing HA-based education teams and BC Pharmacy Association member services team as well. With over 70 releases and hot fixes later, we continue to keep up with the ever-evolving needs of our COVID vaccine campaign. With vaccine for the 6 months to 4 years old, the fall booster campaigns, and this year, the universal influenza campaign that is currently breaking records. It's important to note that much of this functionality and value delivered through IMSBC is thanks to the integration with the Provincial Immunization Registry. So even if you are a provider that did not use IMSBC to document and instead used the Provincial Immunization Registry or an electronic form, that information was still all collected into this provincial registry for record completeness and analytics. Additionally, for infants and children born in BC, did you know that the Provincial Immunization Registry record is created for them at birth? So it's almost instantaneous. As soon as the baby is born and the PHN created, this information flows to from the Enterprise Master Patient Index to the Provincial Immunization Registry, and then the record is created. Children then get forecasted for that vaccine or for their vaccines beginning at 2 months of age for general vaccines, and then at 6 months for COVID, and then for influenza as well. It is worth calling out, as you all probably already have heard, that the infant and child COVID and influenza immunizations programs we're not quite where we'd like to be for the vaccine coverage, below target levels for this age group. I think yesterday it was reported to be at around 51%. So we all see the impact of this respiratory illness season on our hospitals and our staff. And through the research team with our government digital and experience branch, we're looking at ways to reach out to parents in more specific ways, given the rates. Even if there is one parent with a child out there under 5 right now who's on this call that gets online and books their child to get vaccinated, then I'm even more grateful for having joined you today. And I'd also love to call out Elizabeth Lee, who's our director for the Provincial Public Health Information Systems with PHSA. And Elizabeth is here supporting any questions that you might have that you post on the chat. And so it's just been such a wonderful partnership between the Digital Health Strategy Office and everyone in the province for what was accomplished during this campaign here. So I leave you with this. The way that we performed the evaluation, again, it was amazing, the kind of data that was collected in what I call our learning. We were a living learning system where we would take real-time data and apply that to our operations and to the way that we offered care to people. And through our joint efforts, we were able to achieve and become one of the best protected populations in the world. Earlier this year, almost all of our provincial restrictions were lifted in April, in large part due to the high vaccination rate. Registration of over 4.5 million people. Can you imagine having that kind of database and being able to engage with people across other clinical pathways and achieve wonderful population health outcomes there? You can continue to read the evaluation results here on the screen, and we will continue to engage with our public to be able to understand how might the campaigns and engagement evolve over time as we progress beyond this pandemic. So with that, our partnership cross-sector, cross-disciplines, we continue to learn. As you all know, I'm just heading off after our great conversation this afternoon to the coordination committee, and so that we can continue to learn and understand with feedback from our citizens through our online, in-person, and phone and service options through Service BC to gather, what it is again that we need to do to tailor our supports to the needs of our people. Regardless of the size of your project, consider these recommendations. A clear vision and citizen-centered goal. What was it for us? Get shots in arms, save lives, collect the data. Clear leadership and accountability. Any issues that any health authority or pharmacy or physician or what have you had, we all said, okay, we got to bring this to the coordination committee. We got to bring it up to Penny and Dr. Henry. Agile business processes, agile finance, and agile product delivery. So if anyone is interested in understanding more about the Scrum framework and how to bring a team together around product management and product methodologies, please let me know. I'd be happy to work with you. And finally, through the ups and downs, consensus and disagreements, the net sum, though, is that we have proved we can positively impact our health and well-being with the help of our digital enablers when we work together and put people first. Thank you so much.
Thank you, May. It's amazing to hear that incredible initiative and the impact we all know that has had on our lives and getting us through the pandemic, and that it was initially built in 9 weeks from idea to release. That's extraordinary, and I think should all be really really grateful to the work of your team. We are right on track for timing. If there's a burning question, we could take one now, but we might wait till the end of the talks just to give everyone time, if that's okay. Thank you once again. So next speaker we have is Dr. Lori Brotto. So welcome, Lori. Lori is the Executive Director of the Women's Health Research Institute. She's a professor in the Department of Obstetrics and Gynecology at UBC, and also Canada Research Chair in Women's Sexual Health. Lori is also an allied staff member at the Vancouver Acute Health Services and an active leader in digital health research. So I'm going to pass the floor to Lori so we can learn about the amazing work that she's doing.
Thanks so much, Beth. Let me just confirm that you're seeing just my slides and not a presenter view.
We're all having the same issue today. I see that.
Yeah, when there's dual screens.
Yeah.
So it's working.
No, it's not working.
It's not, you gotta switch.
How about now?
Yes, yes.
All right, thanks. So thank you, Beth and Tibor, for organizing this incredible meeting and the quick pivot to online. And I want to acknowledge that I'm presenting this on behalf of our entire team, and our work has gratefully done on the unceded territories of the Coast Salish peoples, so specifically the Musqueam, Squamish, and Tsleil-Waututh, and we give tremendous gratitude to the first peoples of this land to allow us to do this work. Of course, over the last few years, this work has been entirely virtual, so there have been people coming from many, many different lands across Turtle Island converging on this work. So my presentation is more of a case example of a research question born out of a patient interaction in the clinic. So I'm a registered psychologist in BC. My clinical practice is focused on addressing and managing sexual dysfunction and vulvovaginal pain conditions. And so the research question, again, developed out of really a very distressing patient that I had the privilege of working with. And that was about 21 years ago. And so the journey I'm going to take you on is where that interaction has led us to today. So eSense from sexual health program from concept to commercialization. So just really briefly, I'll start just to orient the audience. What do we mean by a sexual concern? How common are these issues? What do we know about how well in-person treatments work and what are the barriers around those? And then a bit of the road to developing our digital health tool that we call eSense, and a living snapshot of where we are right now, which is nowhere near the finish line. So in brief, there have been many large population-based prevalence studies looking at just how common sexual difficulties are. And I think a lot of people are really staggered to read just how common sexual difficulties and complaints are, because there is this pervasive societal myth that we live in a sex-saturated society. People engage in easy and satisfying sexual activity. And in fact, what we know is that sexual difficulties and distress is extremely common. You can see some of the data there that show the gender-based breakdown, with lack of interest or low desire being the most common issue, both in women and in men. We have very few population-based prevalence data on gender diverse people, but our group and several others are starting to really do better in asking those questions with our gender diverse populations that we work with. So despite how prevalent these difficulties are, actually very few people seek treatment. You can see the data here, about 16% of sexually active women and 14% of sexually active men will ever speak with a healthcare provider about their difficulties. And instead, many of them simply suffer in silence. And you can see some of the studied barriers around that. So there are patient barriers, feeling embarrassed and awkward, don't want to bring this up with a care provider that, also gives them their COVID vaccine and other things. And then there's a number of healthcare provider barriers that have been documented. Absolutely, we're not doing a great job in our education system, in medical schools, et cetera, around equipping future healthcare providers around the range of sexual difficulties and how to manage them with evidence-based tools. And as a result, many of them believe that, well, there's nothing that is available to treat them, so why bother asking? And then there's this other issue of still to this day, not fully embracing the fact that for a lot of people, sexual health is a core aspect of their quality of life. We know that when a person has sexual difficulties, it impacts mood, relationship function. It directly, in fact, it's the leading contributor to non-compliance with medications. And yet we still have very, very low funding rates dedicated to addressing sexual health topics. So I've long been interested in this question around what are the evidence-based treatments, particularly for women's sexual dysfunction. And we know that although there are 2 Health Canada approved medications to address low desire in women, the uptake by women themselves, but also their healthcare providers, has been extremely low. And that's another talk for another day, but suffice it to say, the actual benefits that people experience are quite meager and only marginally better than placebo, and they're accompanied with lots and lots of side effects. So my work has largely focused on taking mindfulness-based interventions. Mindfulness, for those of you who might be less familiar with the term, has roots in Buddhist meditation, but in the last 40 years, a secular version of that has arisen in Western healthcare, which essentially boils down to paying attention on purpose and non-judgmentally. And mindfulness has been tested and tried and in fact adapted in many, many healthcare settings around the world. In fact, there was just a paper published last week in JAMA showing mindfulness to be more effective than some of the leading treatments for anxiety disorder. So mindfulness has long been shown to be effective for things like chronic pain, anxiety, depression, relapse of depression, ADHD symptoms. And I became very interested in mindfulness as possibly a tool for addressing sexual dysfunction in about 2002 when I was a fellow at the University of Washington. So over the years, we've developed, adapted, and tested mindfulness-based interventions in a number of different populations, primarily women and gender diverse people who experience low desire and vulvovaginal pain. And we recently completed an RCT that was funded by the Canadian Institutes of Health Research to compare mindfulness to basic education that someone might get if they were lucky enough to get into the offices of a healthcare provider or find good resources online that really address sexual dysfunction. So in brief, what we found is that mindfulness, which are the 4 bars on the left, and each of those different colored bars are time points, significantly and quite clinically meaningfully reduced sexual distress in women compared to psychoeducation and improved sexual desire. So I mentioned the known barriers. So we have, this quite elaborate series of studies showing that mindfulness works. That it is very acceptable to people, but the problem is that even if we were to offer it in a healthcare setting, that these barriers that we addressed earlier still exist. So that led me and my research partner, Kyle Stevenson, who's a professor at Xavier University in Cincinnati, and who's an expert in cognitive behavioral therapy for sexual dysfunction. It led us to start brainstorming around, could we take these evidence-based tools and create a digital platform to deliver them so that people could work through them in the privacy of their own home? So over the series of about 4 years, and alongside patient partners in this work who helped us co-design the language, the colors, the messages, the cases, the illustrations, pretty much even the homework sheets, we developed a program that we call eSense. And eSense delivers, there's 2 arms to eSense. One is cognitive behavioral therapy, 8 modules that people work through. And the second module is mindfulness-based therapy. And although there's not a clinician that is interacting with the person as they're working through eSense, they do meet every week with an undergrad trained navigator who is trained in things like active listening and validation and mostly technical support. And that's been found to increase acceptability, but also engagement with digital health tools. So here's just a few screenshots of what eSense looks like. So all the skills are delivered. And again, these are the exact same skills that were tested and found to be efficacious in our face-to-face treatments. We then undertook a number of different feasibility studies. Again, for example, we would have a patient or a participant in this case sit in front of the computer, and as they were working through the modules, a researcher would be in the room with them, listening and documenting as the patient was interacting with the screen and saying, oh, that actually doesn't make sense to me, or that looks really good and I really like that, and oh, this is what's missing here. So it was like a real-time data capture. It's called Think Aloud. It's a well-validated program. So that process led us to do quite extensive usability and feasibility testing. We have 3 publications that show all of the steps of usability and feasibility, which also then led us to significantly revise eSense to address all of the many of the comments, I shouldn't say all, many of the comments that our users provided for us. And those are the 3 papers in case anyone's interested. So we then received funding from Canadian Institutes of Health Research and Michael Smith Health Research BC, an Innovation to Commercialization grant to undertake a randomized clinical trial. And we have an amazing postdoc, Liz Mahar, who I think is on the line, who's been leading and almost completing. I think we have just a few people left to recruit through the RCT, comparing the two arms against a control group. And we're just about to launch what we call Scale Up, which is an implementation science study design in partnership with about a dozen clinics across North America to deliver eSense to patients who are waiting on a wait list. So these are real people in the community who are waiting to see a clinician for their sexual health concerns. Maybe it's a psychiatrist, maybe it's a family doctor, maybe it's a sexual medicine physician or therapist, and they're given the option while they're waiting to work through eSense. So we're not so much looking at efficacy as much as we are looking at questions such as who is likely to take this up? Who are the folks who take this up versus decline it? And how engaged are they with it? And of course, since it's a scale-up implementation science study, many of the controls that scientists are used to in RCTs have been loosened. And we just submitted the ethics for that. So hopefully we'll be able to ramp that up pretty soon. We also have undergoing at the moment a number of adaptations of eSense. So one project that my grad student Geneviève is working on is adapting eSense to cancer survivors. This is done in consort with patient advisory groups who, again, work through the material and provide feedback on what needs to be adapted for those populations. So we have adaptations to cancer survivors, to gender diverse people, to a separate group of trans identified women. And then the next steps, hopefully next year, will be to individuals struggling with vulvovaginal pain. This is my last slide, and just to show you the kind of the roadmap of what is to come as we hopefully move towards a stage of showing not only that eSense is scalable and implementable, but that there is much interest in the general population at having evidence-based skills that they can at least start to address their sexual difficulties at home. And so my partner Kyle and I have been having quite a round of meetings with investors, tech experts, those who do market analyses, lawyers, and trying to figure out all the steps that might lead us towards having a tool that could be available, including questions of, is this something that could be, approved by Health Canada as a device, and thus available free of charge to people who wish to use it, or is this something that people would pay a subscription for down the line? So those are all questions that are to come, and I would be very happy to share our learnings and also kind of share in the experience with anyone who might be at a similar stage in their work. Anyone who's interested in finding out a bit more about eSense, there's a QR code. And if not, thank you very much for your attention.
Thank you, Lori. That was a really fantastic presentation, and it's incredible to see the journey of development over time from that one patient and research idea into this incredible platform. And I know we're going to hear a little bit more about it later, and there is a question. Can we please see the QR code once more? Do you mind putting that up for just a little bit longer? And while you're doing that, we have had some questions coming in. A lot of them I'm going to reserve for the end as questions for all of our speakers, but just a quick one. There's a question about, have you given any thought of how to make eSense accessible to people who might not have the computer or Wi-Fi access at home?
Yeah, so thank you for that question. It's not an app. It's actually mobile friendly. And the reason for that is in the early stages when we were doing patient engagement, that was one of the comments that people made to us. And they said they'd like to be able to go into their library and use a desktop computer there to access eSense. And so at present, it's not an app, although that's some of the feedback that we're getting is that eventually we will want to appify this and probably have two versions of it, one that is sort of as a website program and one as an app.
And that's totally doable, and that gives you opportunity to access people in a variety of ways, which is kind of the wonderful thing about digital platforms. There's lots of mediums and lots of ways to get a tool out there. So thanks once again, Lori. And we're pretty much right on schedule, so I appreciate the speakers' attention to that. So moving right along, our next speaker, I'm very pleased to welcome Dr. Shazhan Amed, who is a pediatric endocrinologist and head of the Division of Endocrinology at BC Children's Hospital. She's also a clinical professor at UBC and a clinician scientist at the BC Children's Hospital Research Institute. Dr. Amed is a health service and population health researcher, and she's here to talk to us about one of her many projects focused on childhood diabetes and type 1 diabetes. So please go ahead, Shazhan.
Thank you, Beth. I just want to confirm you can see my slide.
Yeah, you're perfectly in presentation view.
Perfect. Great. Well, thank you for the opportunity to talk about TrustSphere, a collaborative and personalized digital care experience. Let me there we go. So the hope for today for all of you is that after this presentation, you will understand the key steps in developing TrustSphere, which is a digital health app co-created with patients, families, and healthcare providers. Pediatric diabetes is TrustSphere's first test use case. So let me start by telling you about Ethan. He's an 8-year-old boy diagnosed with type 1 diabetes. And at the time of his diagnosis, his parents were wrought with worry and devastated by this life-changing, lifelong diagnosis. And at the time of his diagnosis, Ethan and his parents were given this paper binder, which is what we give today. And they participated in 3 full days of diabetes education, where they learned how to manage Ethan's diabetes at home, at school, when he's at hockey practice and birthday parties. And over the years, as Ethan has lived with diabetes, this paper binder has expanded with information such as glucose logs, written paper notes from Ethan's doctor outlining his new insulin doses, paper handouts on the latest diabetes technologies like insulin pumps and glucose sensors. And Ethan's family carries this binder to all of his appointments. But what if this paper binder was replaced by a single trusted digital solution where all of this information was digitally accessible to the patient, to Ethan and his family, his healthcare team, and even others within his circle of care, like his family doctor and the support person in his school? We are taking a systems approach to solving the complex problem of lack of digital trust and digital infrastructure to support clinical care and research and prevent unnecessary duplication of tests, miscommunication, and inefficiencies. TrustSphere aims to support the complex journeys of children and families living with chronic disease by addressing data silos and offering a digital infrastructure that shares critical information like patient-generated health data from glucose sensors or care plans and educational resources. We believe that TrustSphere will enable a patient and family-centered, collaborative and personalized digital care experience. For example, it will support full transparency and fast delivery of information, ensure that care is aligned with patient goals and is collaborative, coordinated, and accessible. And patient and family viewpoints are respected and valued, where the patient and family are involved in the decision-making process. We have embarked on a journey of co-creation of TrustSphere with key stakeholders. Our stakeholder engagement included parents of children less than 18 years of age from Canada and the United States, youth aged 16 to 17 years old, parents of children living with type 1 diabetes, and pediatric diabetes healthcare providers from BC Children's Hospital and across the province. Our engagement strategies included quantitative surveys, qualitative bulletin boards, subject matter expert interviews, and group consultations, where we gathered perspectives on digital requirements for trust and for an app that would support collaborative pediatric diabetes care. And through all of this engagement, we generated key insights that then informed the development and design of TrustSphere. So one of these key insights was that families described a pain point, which was the lack of trust in digital solutions and the lack of a patient-centered, digitized assent and consent process for the secure use of their data. What patients wanted was a trusted doorway and consenting process when using digital health apps for clinical care and for research. Our private sector partners have developed TrustSphere's core technology to create a trusted digital front door that safeguards identity management and personal data through identity authentication and verification, patient-centered consent and governance workflows, and data translation and standardization. And this trusted digital front door allows patients to securely access innovative digital health apps that support patient-centered, personalized care experiences. Another key insight from patients and families, as well as from health providers, is the need for a personalized collaborative care experience and a single point of access platform and dashboard. So remember Ethan. Now he's on an insulin pump and a glucose sensor. And these devices generate vast amounts of data that Ethan and his family needs for the day-to-day management of his diabetes, and that they also need to share with their healthcare providers, like their diabetes team. But this data exists in different places, requiring them to remember different passwords and IDs. And the problem is that they never get to see all of this data in one place. So imagine if Ethan, his parents, and his diabetes team could simultaneously review this data in a single dashboard that also has Ethan's diabetes action plan outlining his insulin doses and his glucose targets and even his personal goals. But to create this collaborative clinical experience, TrustSphere tackles another pain point, which is accessing the data we need when we need it. We've partnered with diabetes device and software companies like Gluco, Dexcom, and LifeScan to support this data integration. Data from wearables and devices can be continuously streamed and synchronized into a patient dashboard that's viewable by the patient and healthcare team. The patient and the healthcare team can view the data between clinic visits to support diabetes management, like insulin dose adjustment. And the dashboard can be used as a collaborative tool during clinic visits, truly putting the patient at the center of their care. In the future, we hope to explore opportunities for integration with EMRs like CST, BC Health Gateway, and other wearables and devices. The design and development process for TrustSphere included 3 rounds of usability testing over about 1.5 years with parents and youth living with diabetes, as well as pediatric diabetes clinicians from across BC. And we used a similar process to what Dr. Brotto described in terms of Think Out Loud. Each round of usability testing was then followed by a rapid data analysis and then iteration of the product to incorporate the feedback that we received from stakeholders, with the eventual development of a minimal viable product in 2022. So let me introduce you to BC Children's Hospital Care Hub, which is the downloadable version via the Apple and Android app stores. This is the patient-facing app that is called the BCCH My Care Hub account, but TrustSphere is the consortium of partners who provide the infrastructure and security for this application. I'm going to walk you through some of the key features of this app, including Care Team and My Data for Research. But first, let's do a quick walkthrough through the trusted doorway and connection to devices. The first step in using TrustSphere is creating a Care Hub account. And first, users must validate their identity via the BC Services card application or through verify.me, which is a technology that verifies identity using banking credentials. This is a key step in ensuring security and who has access to all of the data within the Care Hub. And during this process, a parent and a child also navigate through patient-centered consent and assent workflows that were co-developed with our technology partners and our ethics and privacy subject matter experts on our team. And the purpose of this is to ensure that users understand how their data is being held securely and how it will be used for clinical care delivery. Once the CareHub account is created, users can connect their devices so that patient-generated data, in this case from glucose sensors or insulin pumps, can actually stream directly into the CareHub databank. Just as an aside, healthcare providers or clinicians have their own HCP-facing portal and sign in using their PHSA credentials, which is the identity verification for the healthcare provider. They log in as a healthcare provider on the web-based care team site and are immediately directed to their PHSA credentials, which then verify their identity and provide them with access into the BC Children's Hospital Diabetes Clinic, where they can find the profiles or action plans of all of their patients. So here you have the MyCareHub account. And first, we're going to talk about Care Team, which is the clinical part of the platform. This is an example or a screenshot of Care Team's dashboard, where you can see that glucose levels from a glucose sensor are being pulled into the dashboard. You can see here is what we call a river diagram, which is the information of the aggregate of the glucose levels that helps us to adjust insulin, and not just the healthcare provider, but also the patient. In addition to seeing all the glucose values in the same dashboard, a patient can see their insulin levels or their insulin doses. They can see recent updates to these insulin doses, either by someone in their care circle or by their diabetes team. They can also see recommendations from their clinician or their clinical team, all in one place, as well as easy to access educational resources and documents that they would use frequently when managing certain scenarios, like being sick with diabetes or having to deal with low blood sugars. In addition, through the Care Team care plan, the diabetes team or clinical team can provide the patient with tasks to complete prior, for example, to their clinic appointment. So here you can see that different tasks have been assigned. A clinic visit preparation form was assigned to the patient. The patient can complete that clinic preparation form right inside the app. And then the results of that form are available to the clinical team as well as to the patient, so that at that clinic visit, they can personalize the visit to really meet the patient where they're at. So these are some of the key features of what the clinical part of TrustSphere offers. I would like to also show you the My Data for Research application, which is a novel application developed by this team that provides a digitized patient-centered research consent and assent process. When a patient enters the My Data for Research application, they are given education and information about what it means to participate in research. And this is a way to engage families in participating in the research process. If they're interested, they can actually go through a digitized assent form for the child and consent form for the parent to agree to participate in research. In this case, they're agreeing to participate in a TrustSphere registry, which then allows us to use the data in the CareHub for the purposes of research. When a patient, say a child and a parent, assent and consent, the data is then shared with scientists and de-identified and transferred to a TrustSphere registry at BC Children's Hospital Research Institute. During this consenting process, the family is also asked to provide their PHN for the purposes of linkage. And if they choose to do so, it gives us the ability to integrate and link data from other data sets, for example, from a clinical diabetes registry or even administrative health data. I'm pleased to announce that the TrustFair pilot study launched in October 2022. And although it's very early days, we have successfully onboarded 6 families onto the platform. And the early data looks very promising. 3 out of 6 families agreed or strongly agreed they would use TrustFair frequently. 5 out of 6 agreed or strongly agreed that TrustFair was easy to use. And all families agreed and strongly agreed that their child's data was safe and secure, and they appreciated the security features such as the BC Services Card identity verification. We also gathered data from healthcare providers who use TrustFair in their clinical interactions. And again, very promising feedback. 100% of healthcare providers thus far have stated that TrustFair improved their pre-clinic preparation. 80% stated that it improved their interaction with the patient and family during the visit, and 90% were satisfied with using TrustFair. We have some quotes from families when asked, why will you use the BC Children's Hospital Care Hub? One parent said, it's at our fingertips. I can easily review glucose levels with my husband from my phone when I'm making decisions to adjust carb ratios and basal rates. So really looking at that self-management. Another parent said to organize information from BCCH, keep track of tasks, etc. We believe that TrustFair's potential is really unprecedented. It will provide clear data governance, privacy, and security to achieve trust, remove data silos to create a robust health data ecosystem, improve data use for collaborative decision-making, patient-centered care, and research and quality improvement, empower patients and families in self-management to optimize their health and wellness, and deliver a better patient and family experience. The future of TrustFair is promising and exciting. We imagine wider implementation in pediatric diabetes across BC and Canada, adaptation and scale for use in other pediatric chronic disease conditions, leveraging TrustFair for secure access to innovative digital health apps, bolstering the use of patient-generated data to improve care quality and chronic disease management, deepen patient engagement and research across BC and Canada, and enhance access to a broad range of near real-time data to support a learning health system via data integration and linkage. And I just want to acknowledge all the work I presented today is the collective effort of everyone on this slide. And I really want to stress the fact that this has been a huge team effort. And although I can't name every single person, I just want to show my deepest gratitude to have the opportunity to work with this team, all of the researchers, as well as all of the many people behind Identos, Smile CDR, Care Team, and SecureKey, who are our amazing industry partners. Thank you so much, and I look forward to participating on the panel.
Thanks, Shazhan. That was a great summary of what is an incredibly complex project. The consortium model, I know that we'll have time to talk more, but I'd love to hear a bit more about the experience of bringing so many partners together to solve a real clinical need. But we do have time for questions later, and I have seen a few come in the chat, so we will do that. Just in the interest of time, we're going to move on to our final talk to give our speakers the time that they require. So our last talk, we actually have a team of speakers. So I'm delighted to welcome both Meereen Poonja and Chetna Jetha. Meereen is a clinical leader at PHSA's Office of Virtual Health, and she's responsible for integrating and implementing new practices in virtual care at BC Children's and Women's Hospitals. Her background includes over a decade of experience as a frontline social worker. She began working in virtual health in 2021 and has been part of enhancing efficiencies, increasing access and equity within our healthcare system through virtual health mechanisms. Chetna has a Bachelor of Occupational Therapy from the University of KwaZulu-Natal in Durban, South Africa, and 10 years of clinical experience in a variety of settings as an occupational therapist. She has a passion for neonatology and pediatric care and has a current role at Sunny Hill Health Center. And so please join me in welcoming our final speakers. Please take it away.
Great, thanks, Beth. I'm just gonna share my screen and hopefully this works. What do you see? Okay, perfect.
Good to go. Thanks, Meereen.
Perfect. Great. Over to you.
Thanks for the introduction, Beth. And like she mentioned, my name is Chetna and I'm an occupational therapist with the Cerebral Palsy Early Diagnosis Clinic at Sunny Hill Health Center, located at Brotto.
Great, thank you. And my name is Meereen Poonja, and I'm a clinical leader with the Office of Virtual Health. Before we get started, Jetha and I both wish to acknowledge that we are presenting from our individual home offices, which is on the traditional lands of the Musqueam, Squamish, and Tsleil-Waututh Nations. We would further like to pledge our personal commitment as healthcare providers in ensuring that we are offering healthcare services that are safe, accessible, and appropriate to the Indigenous populations whose land we live, work, and play on. Today, we're going to be talking about a collaborative project between our two teams that is leading the way to expedite the diagnosis of infants at risk for cerebral palsy, or CP.
International guidelines recommend that CP should be detected as early as possible to enable the implementation of diagnosis-specific early intervention, which optimizes neuroplasticity and functional outcomes. High-quality evidence indicates that CP can be accurately diagnosed before 6 months of age, yet the average age of diagnosis in Canada is 18.9 months, and much later in BC at an estimated 25 months. In 2017, the BCCP Advisory Committee was formed with the aim of closing the gaps that exist in the care for children with CP and their families in the province. They identified that there was no diagnostic pathway that was being used in BC and established the goal to develop one for children in the province. Following a robust literature review and environmental scan, the BCCP Advisory Committee made the recommendations to adapt the American Academy for CP and Developmental Medicine's evidence-informed care pathway as a structure for use. This led to the establishment of the CP Early Diagnosis Clinic at Sunny Hill Health Center in November 2021. The clinical team is comprised of developmental pediatricians, a pediatric neurologist, an occupational therapist, and a nurse clinician. As a first step in the diagnostic pathway, the Early Motor Assessment Clinic, a division of the CP Early Diagnosis Clinic, was formed to complete the general movements assessment to identify infants who require further assessments in the CP Early Diagnosis Clinic. For infants less than 5 months post-term age, international clinical guidelines for the early detection of CP recommends the combined use of clinical diagnostic tools as demonstrated in this care pathway, including the General Movements Assessment, or GMA. The GMA is a reliable and valid diagnostic tool which functionally assesses the integrity of the developing nervous system. It has proven to be a cost-effective method for the early detection of CP, which is used by health organizations around the world. The GMA involves the observation of an infant's spontaneous movement. With consent, the infant is positioned on their back and the video recorded for 2 to 5 minutes. The video is then analyzed by a GMA-trained professional. General movements between 3 to 5 months post-term age are described as fidgety movements and can be classified as normal, abnormal, or absent. General movements which are classified as absent fidgety movements are highly predictive of later neurological deficits, particularly of CP. Of all infants who are at risk for CP, there are a number of patients who are referred to BC Women's Neonatal Follow-up Program, where the GMA is completed at their 4-month visit. However, there remained a group of high-risk infants who were not receiving the GMA. These infants were therefore at increased risk of a delayed diagnosis and intervention. It was identified that this gap in care can be addressed by completing the GMA in the Early Motor Assessment Clinic in order to ensure the provision of appropriate and effective care. While patients and legal guardians can come into the clinic for an in-person assessment, there were several issues that still needed to be addressed. Firstly, there was an access issue. The clinic provides Tier 5 and 6 levels of service to patients residing across the province. The travel costs and time required are an extra burden to families, particularly those from remote areas. scheduling an in-person appointment can be challenging for families with limited financial support and/or those who don't have access to a personal vehicle. This would result in a segment of the population that would be excluded, creating inequities around who is able to access the service and get a timely diagnosis of CP. Further, if the infant comes into the clinic and is not in a calm state, it results in longer appointment times, or the appointment needing to be rescheduled so that the infant can be assessed when they are in the required state for the assessment. This would be inefficient and further creates stress to the infants and legal guardians and impacts the clinic's ability to maximize how many new patients we're able to see. Additionally, the GMA during the fidgety period is a time-sensitive assessment which must be completed between 3 to 5 months post-term age, as fidgety movements fade out thereafter. This limited window in which the assessment must be completed can make scheduling difficult, particularly if an infant is not in the required state and must then be rebooked. One way to address this problem was to have legal guardians record their infant at home, which would then be sent to the clinic for assessment by the team. Evidence has shown that when provided with an instructional leaflet, the GMA videos recorded at home by legal guardians are valid for clinical assessment. However, the process of securely transferring the recording from legal guardians to the clinic required innovation and support to ensure the safety of personal health information. The CP Early Diagnosis Clinic team therefore approached the Office of Virtual Health to identify a secure file transfer platform that meets all the necessary requirements.
The Office of Virtual Health leads and provides strategic direction and innovation for the virtual health initiatives at PHSA. We work directly with the clinical teams to solve complex health problems through the integration of virtual and digital technologies into their clinical and/or operational practices. Understanding the clinical gap that Chetna just spoke about allowed the OVH team to firstly build out the technical requirements. For example, from a technical perspective, we wanted to ensure that the platform was easy to use, had multi-device capability, and was in alignment with PHSA's privacy and security policies. We also considered the needs of the patient population. For example, we wanted to ensure that the platform would work for legal guardians with diverse backgrounds, such as diverse levels of digital literacy, education levels, and be available to legal guardians who reside in diverse communities across the province. Once these requirements were validated with the clinical program, our team performed an environmental scan of possible solutions that including assessing the viability of Amed's internal file transfer solution. The outcome of the environmental scan was a recommendation to proceed with a solution called sync.com. The OVH team then worked closely with the vendor to perform user acceptance testing. This process includes stress testing the platform to ensure that the platform would function as intended once we go live. Simultaneously, we worked with the clinical team to map out a future state workflow. The workflow identifies the various steps, dependencies, and roles and responsibilities once the new solution is integrated as part of the clinical work. We developed a robust evaluation plan in collaboration with the clinical team, and we'll talk a little bit more about this in a bit. Our education team worked with the clinical team to understand what educational tools would be the most appropriate for this project. It was decided that a quick reference guide for both the clinical team and the legal guardians who will be recording their infant would be the most appropriate educational methodology. On the screen, you will see a one-page document that was created by our education team. This document is a quick reference for legal guardians on how to record their infant in a manner that would enable success for an assessment. In addition to the reference guides, we also provided training to the staff by demonstrating the platform and reviewing everyone's role. We will now walk through the new workflow. First, the clinic's intake coordinator reviews the referral, calculates the ideal window in which to perform the GMA, and passes this information along to the booking clerk. The booking clerk contacts the legal guardian to obtain consent for email communication, inform them about the file sharing platform, and confirms access to a smart device. If the legal guardian would like to proceed with the virtual GMA, an email is sent to the legal guardian containing the clinic introduction sheet, the guidelines for recording and uploading the video, and a personal link from the sync platform that will allow them to upload the video once recorded. This email also specifies a 1-week date range in which the legal guardians are to record and upload the video, as this is a time-sensitive assessment. During the date range specified, legal guardians record their infant while awake and calm according to the instructions provided. Once the video is recorded, they then use the personalized link to upload the recording of the infant. Once uploaded, the recording is automatically sent to the clinic. The OT then reviews the recording, scores the assessment, and compiles an assessment report. The booking clerk contacts the legal guardian to schedule a virtual follow-up appointment so that the OT can review the assessment with the family and discuss next steps. As mentioned earlier, an evaluation plan was developed utilizing a combination of qualitative and quantitative research methods for collecting data. Following the virtual appointment where legal guardians review the results of the assessment with the OT, they will be provided with an electronic survey. This survey aims to understand several objectives. First, we want to understand the legal guardian's experience during this journey. Specifically, we want to learn about the effectiveness of the educational instructions provided. We want to understand the psychological impact of recording a video of their child for the purposes of a clinical assessment versus attending an in-person appointment. We also want to learn how legal guardians found the sync platform. Was it easy to use? And do they have confidence in the safety of sending the recording through this method? We also want to understand if this project allowed for equity of healthcare services. Within the survey, we have requested legal guardians to provide their postal code. This information will be cross-referenced with publicly available data on Wi-Fi connectivity and will allow us to evaluate if there was equity in experiences of families using the platform from the various communities across the province. Finally, we want to understand the clinical team's experience with using the platform. We plan on interviewing the clinical team to learn if they have experienced any challenges and if they had to support families with using the platform. This information will help us to understand if we have optimized efficiency within the clinical workflow and if the tools we have developed adequately support our partners in the intended outcome.
As our team went live with Sync in September, it is too early to identify how the project has and will continue to impact the patient population and the clinic. We do, however, expect a number of anticipated benefits that will address the initial healthcare problem that the clinic was experiencing. We anticipate the use of a secure file transfer system will reduce the impact of physical and financial obstacles, thereby promoting equitable distribution of services and improving the accessibility to receiving care. In doing so, we will be able to provide a more timely diagnosis, thereby minimizing clinical harm caused by delay of care.
It is also expected that this solution will improve efficiency of the clinical services by increasing the capacity of the team to perform a higher volume of assessments. While this solution is being offered to all children who meet the referral criteria, the team respects the family's autonomy by continuing to offer the choice to attend an in-person appointment according to their needs and preferences. And finally, we anticipate that the secure file transfer system provides a safe platform which protects personal health information while enabling the delivery of appropriate and effective care that is informed by evidence and best practice to achieve the best possible outcome for the health and wellness of children with CP and their families.
So what is the impact on the health and well-being of these infants and their families? Clinical guidelines exist which indicate that a conservative wait-and-see approach should be avoided when clear clinical diagnostic indicators exist. By increasing accessibility to the GMA, our team is able to provide more equitable distribution of CP diagnostic services, the benefits of which are numerous. Firstly, evidence indicates that CP-specific early intervention using intense motor learning task-specific approaches optimizes neuroplasticity and improves children's motor and cognitive outcomes. Furthermore, there is evidence that delayed diagnosis has a negative impact on the mental health of legal guardians. And finally, early, regular monitoring and treatment for the known musculoskeletal complications of cerebral palsy can prevent the onset of hip dislocation, scoliosis, and contractures.
This project would not be possible without the support of the many, many people who are part of the team. You will see their names on the screen.
Thank you for your time, and we look forward to answering any questions you may have during the Q&A panel.
Thank you so much, both of you. That was a fantastic presentation, and I'm very much looking forward to having you back another time once the evaluation is complete to see how that impact was achieved and where you're at. Just a quick question for both of you as we move into the panel discussion. It seems like this is a platform that could apply to a variety of clinical needs where secure file transfer is required. Is this now that it's been vetted and it's available for this clinical program, is this a platform that would be accessible to any other clinical programs to use if they have a need?
Yeah, good question, Beth. Chetna, if you're okay, I'll take this question. I think what we want to do is really evaluate how this platform worked and ensure that it works well before we think about scalability and expanding it to other programs.
Yeah, that makes sense. It's important to make sure it's working as intended.
Right.
So I'm gonna move on, and we did have a few questions in the chat, but I encourage anyone who does want to ask one of our speakers question. We have about 10 minutes for additional questions, so please type in your questions in the chat either to me or to everyone, and we'll try to address them all. The first question that came in a little bit earlier was actually for May, but I think it applies to all of the speakers. And the question was around and how do you address needs of the most vulnerable and minority groups within your programs right from the beginning, speaking specifically about people with disabilities and the impact of digitizing services for those groups. So maybe May, you want to go first, and if anyone else wants to jump in, they can.
Thanks so much, Beth. Well, in terms of reaching out to the most vulnerable, as an example, I live here in Vancouver, and Vancouver Coastal actually had a team of clinicians that went to where they lived. So in different communities, and many of you know downtown East Side, for example, it wasn't just through digital technologies that we were able to reach out to people. So, before, it's funny because we're celebrating Digital Health Week, and here I am still promoting. There's a mix, right, of this is omni-channel healthcare. So yes, pursue digital for those that can access it, but we still offered telephone and we still offered in-person services to be able to reach the maximum, size of the population of our market. So that was really critical for us to be able to be where the people are. Similarly to the rural and remote communities, we did work with health authorities locally to be able to reach out to those remote communities. For example, the very first implementation, so after that 9-week implementation of IMS BC, where did we try it out? We didn't try it out in Vancouver. We actually tried it out on Cortes Island, of all places. No Wi-Fi. Everyone had to take boats to go across to the community center there. So it was really, extraordinary for us to be able to, challenge ourselves, but also to make the service as accessible as possible. And again, be where the people are and how they can access the service best.
Thank you. Does anyone else want to speak to? It's really about our theme this year around equity and inclusiveness, and I know that Meereen and Chetna, you spoke about how you're explicitly evaluating whether or not you're actually achieving equitable access to care, which is, I think, part of it is making sure you're looking and adapting. But is there any other comment you have about that?
One small comment that I would actually like to make is today is the 17th of November, which is International Prematurity Day, and premature babies actually make up about 40% of the CP population, which was quite fitting for everything today. And they are a very mighty and resilient population, but also vulnerable. So like you mentioned, Beth, we're still in the evaluation process, and it'll be interesting to see, as Meereen mentioned in the presentation, looking at cross-referencing with postal codes and really getting that feedback to, this is our anticipated benefits, this is what we hope, this is what has worked in other countries, but how does that work in BC, where the geography is, well, across Canada, the geography is so different to other countries.
Yeah. And kind of carrying on from that is you're evaluating and you might find that you need to make some adaptations. And this seemed to come up in all of your talks about the process of doing agile methods to develop and adapt as you go and you learn from the system. But then once it's in place, there's another whole opportunity to continue to learn and grow. And so I'm going to pick on Shazhan specifically because your project presents a very complex undertaking with multiple partners. And so how do you address that need to be agile and to adapt as you learn more about your users and the real needs when you're working in this hugely complex environment?
Wow, that's a really hard question, but I think, you know, if I reflect on the last couple years and then what I imagine the next couple years will look like, I think the most important component of that is an alignment of values across all the partners in terms of their commitment to co-creation and listening to the user voice. In the case of TrustSphere, you know, it's the patients, the families, and the healthcare providers. And I think part of where, you know, our success has been is that we've functioned as multiple teams who communicate with each other in a very deliberate way to share knowledge. And so it's that exchange of knowledge between the research team and all of the developers and designers and people who are in the industry partners, and really creating that communication system that I think has been so important. And so the time we spend sharing information back and forth and the collective understanding and commitment to valuing the patient voice and the provider voice, I think is what creates that successful journey of iterative and agile development. There's lots of ways to do it, but it's really the commitment and the alignment of values across all the different organizations that I think has been, you know, our ingredient of success.
Yeah, that's very well said. And I know we'll hear from a couple of your partners later in the vendor and partner session. We are just about out of time. I just wanted to give one final question. The themes this year are about equity and inclusion, but also empowerment. I think, Lori, your platform is a great example of the empowerment component of digital health. Are there things that you feel when you look to the future of eSense that you would bring out more strongly to bring forward that opportunity for empowerment through the device? Or can you reflect on that theme a little bit in the work that you're doing?
Yeah, thanks so much, Beth. I mean, there's so many different places I can take the question of empowerment. I think part of it comes from the all too frequent experience of these patients in feeling invalidated, misunderstood, dismissed, told to go home, that it's all in their head. And so part of delivering these accessible, private, user-friendly digital health tools is validation and normalization. communicating that these are really common concerns, that you're not alone. And that's where the patient engagement piece has been really critical for us in developing and writing the cases that kind of follow, that go through eSense and work through all of the different exercises. The feedback we've been having from our users is they could really see themselves in those cases. And so now as we're moving towards adaptation to these multiple other populations, so as I mentioned earlier, gender diverse people, trans women, cancer survivors, survivors of sexual abuse and genital pain, that's going to be really critical, is that that message of feeling validated and heard and not misunderstood continues throughout. And again, we are going to continue to rely on the patients to guide us on how to get there.
There's our strong closing theme, is listen to the patient voice and work with patients to really have the impact that you want. So we unfortunately have run out of time for this section of section of our event today. So I just want to thank again our wonderful speakers. It's really incredible to see the work that's actually happening now, putting the digital health to work to solve these problems in our care system. There will be opportunity to continue in the chat. If anyone wants to ask questions to the speakers, please go ahead and continue to write things in the chat. But as you know, we've pivoted a little bit in our event, and right now we were going to originally break and have some opportunity to talk more in person, but unfortunately we can't do that. So the next little section for those that are able to stay is we're going to have an opportunity for several of our very important partners to the success of our work at the research institutes in digital health give brief presentations about the work that they are doing. And I'm going to hand the floor over to Dr. Tibor van Rooij, who's going to facilitate this section. So thank you all for listening to me as well. And I'll hand the floor over to you now, Tibor.
Thank you, Beth. Thank you, everybody. This has been so far a fantastic session. And I think although we pivoted to a virtual get together, I felt like it's been very, very close and very exciting to hear all these stories. So now we're going to have some short fire presentation of our partners in this. As you heard from several of the speakers, this work entails a lot of different partnerships and thereby also invites a lot of complexity. The closer you get with a digital health project to real-world implementation, the number of stakeholders and the number of partners just explodes. And so we'll start with some introductions of partners and companies, and then we will have hopefully some chat to conclude our session today. So to that end, a couple of very short presentations have been developed, and the first one is going to be provided by Thrive. If I'm not mistaken, that is the new order of presentations that we just came up with, and the Thrive part will be presented by Dr. Mark Nazimi. So Mark, I invite you.
Thank you, Tibor. It's a pleasure to be here. Good afternoon, everyone. I see a lot of familiar names on this call, including a few of my colleagues from Thrive. So maybe I will just give an introduction of myself and then our company, and provide an insight into some of our exciting solutions that we've been working on and some of our research projects as well. So my name is Mark Nazemi. I lead our clinical and well-being solutions here at Thrive. It's been exciting working on understanding the needs of patients and providers in terms of how we can provide better care for everyone. Previous to joining Thrive, so I've been with Thrive for just over 2 years, and previous to Thrive, I was at Pain BC, where I developed provider-facing educational programs, including programs for people living with chronic pain. So about Thrive, our mission is to really reduce fragmentation by empowering patients and providers, by providing insights into that are actionable and are able to, help them in terms of managing their care. So really what we do as a platform company is provide a centralized place where patients can access all types of care, whether it's, accessing journeys around diabetes, cancer, chronic pain, many different touch points. And so it also includes the ability for people to manage the care of their family members on the platform as well. So in terms of diabetes, Shazhan did a great job in terms of providing some of the background information on some of the challenges within this area. Based on the research that we have seen, that majority of people living with diabetes or any condition for that matter, is that the problem is that they're constantly having to retell their story. And this retelling of that story can be challenging in terms of capturing consistent information around someone's care. And so in terms of diabetes, what we did was we developed an evidence-based journey where it covers both type 1 and type 2 diabetes. It's for both adults and pediatrics and gestational as well. And the journey itself is based on the Diabetes Canada guidelines. So we partnered with them in terms of being able to provide evidence-based educational content that was developed by Diabetes Canada. And really the idea here is that the patients have one place to access all the care they need around their diabetes. And in terms of the journey itself, they're also connected with their provider. So the provider has the ability to manage and modify those care journeys according to the needs of the patient. They can also have additional access to clinical-based assessments as well. We understand that in diabetes, mental health is also an important condition to monitor. And so we provide the ability for clinicians to have access to patient-reported outcome measures around providing PHQ-9 assessments to patients over time. And so really through our diabetes solution, we're able to really support patients in a meaningful way. And they're able to access the evidence-based resources, and it's really tailored towards how they are completing these assessments on the platform as well. So rather than overwhelming with many types of resources, they're able to receive targeted information based on where they're at with their condition. And so we provided a QR code where we have a one-pager information that you can download. If we were supposed to meet in person and talk a little bit more about the details of these, but unfortunately we're doing this online. So I'm happy to also answer any questions that you may have around this particular solution, but maybe we can switch to our next slide. So the next piece that I'd like to talk about is our chronic pain solution. So over the past 2 years, we've worked extensively with clinicians across BC to standardize the care received around chronic pain. And so we have worked with the Interventional Pain Clinic at St. Paul's Hospital, and we've worked with the Bill Nellum's Clinic as well in terms of understanding what should be involved in this intake for people living with chronic pain. And so we started with that work. In fact, one of the exciting research projects that we're currently doing around this as well is we are analyzing thousands of intakes that have been completed by chronic pain patients and creating essentially different types of profiles, making it easier, hopefully, for clinicians to be able to provide targeted interventions for people living with chronic pain. But one of the interesting studies that we recently did was around wait lists. So the QR code will lead you to the poster that we presented at the International Association Study of Pain. What we did was we recruited 200 patients from the Bill Nellum's Clinic. So these patients had been experiencing wait times at least for a month. But in the study, we found out that normally these patients are on a wait list for up to 2 years. And when this has been sort of a story across many different chronic pain clinics across Canada. In fact, we've heard stories around wait times being up to 5 years to receive care. So huge, long wait times. And so we wanted to understand what are some of the fallouts from having to wait so long to receive care from clinicians. And so based on the data that we were able to capture, close to 60% of those patients reported that their health conditions were worsened during this period of waiting, and that around 36% of those saw no change, and only about 5% their conditions were improved. And those people that their conditions were improved were based on additional services they received. The bottom line with this research is that patients that are waitlisted for more than a month, their care or their health tends to deteriorate. And so we're really excited. We just received ethics approval through UBC for a waitlist intervention program that we're planning to run on our platform, where patients receive tailored information around evidence-based self-management strategies to be able to manage their care over time while they're being waitlisted. And then a clinical summary of all their report over that period that they're waited is also provided to their specialists when they do go in for that first appointment. So if you'd like to learn more about that research and what we're doing with chronic pain, please feel free to reach out to me. I know that was a lot of talking in a short amount of time, but hopefully that was informative. Thank you.
That was absolutely great. Thank you very much for that, Mark. And Thrive, of course, also was the company that built a lot of the software that we've all used during the pandemic to make our appointments and whatnot. So I've seen your logo before, and many others may have as well. Thank you for that. We'll keep some questions for later in the sort of like more open discussion. The next presentation is going to be by Gabby Serafini, who will speak to WellTel Health's abilities and capacities. Gabby.
So I wonder if I can ask a favor, because I'm on a train right now. I'm on my way to the airport. Can I go next?
Pardon me?
Because I'm going to get it. I'm on a train.
You're on a train, so you want to skip?
Present it before me.
Yeah,
I'll come
absolutely.
on in about 10 minutes.
Oh, we are so, we are so flexible.
Organized.
We can do that.
Love it. Love it. Thank you.
So next up, if that is okay with the, I'd like to hear more from Dr. Liz Mayer and Ravina Gowda on eSense. Oh, wait. Did I mess that up?
No, it's okay. Ravina, do you want to share your screen? You should be able to.
Sure. Yeah. Give me 1 second.
Well done. Sorry for putting you on the spot, Ravina.
No worries. Okay. There's some videos embedded in this, so please let me know if you can hear it or not.
We see it in present. We're currently not seeing it in presentation mode.
Okay, yeah. I will do that. Okay. So hello, everyone. My name is Ravina. I'm the study coordinator for the eSense project that's being conducted by the UBC Sexual Health Lab at UBC. So this is, we're just going to give you a brief
view of eSense and the website. Yeah. So there's 8 modules for each program, which takes about 8 to 12 weeks to complete. The format is that has text, images, and audio files and videos embedded in the website. And there's also activities that users can do to practice some of the concepts they've come across in the modules. So this is the login page for eSense. So you would have your email and password set up by us, and you would log in. And as you can see, these are our partners here below. And these are the 2 arms of eSense. So that we have the cognitive behavioral therapy and mindfulness-based therapy. And participants are usually are assigned one of these arms by random assignment. And I will show you a brief look into what the arms are like. And this is a welcome video of what eSense is. I will just play this.
Evidence-based information, exercises, and readings drawn from many years of sexual health research. There's strong evidence that many women who use this program experience improvements in their own sexual satisfaction. By making this information accessible in the privacy of your own home, we hope that eSense will be available to countless women who otherwise would not be able to access help and support for sexual difficulties.
Yeah, so eSense was designed to help women who are experiencing sexual concerns and those who are not able to access face-to-face interventions or sex therapy. So eSense was designed to help bridge that gap. And the next page. Okay, so this is the mindfulness arm, and this is like a brief overview of an example of what you can find in the mindfulness arm. So here we have mindful stretching. So finding like ways to observe changes in your body and focus on your breath and do this mindful stretching exercise that can help you develop those skills for mindfulness-based therapy for sexual concerns.
As you can see, eSense is interactive in that it uses a variety of different formats to present the material, which can help increase engagement. Additionally, the use of text, videos, and audio files guide participants through the module material and activities, as you can see here.
Yeah. And next, we'll see a brief example of the cognitive behavioral therapy arm, which is focused on learning and like restructuring your thoughts. Here's a video for that as well.
Throughout eSense, there are case examples where participants follow the journeys of 3 women through eSense. On this page, we see how one of these women, Shalina, engages with an activity in the cognitive behavioral therapy program, where she is guided through the process of identifying her core beliefs.
Yes, so throughout their eSense program, we have case studies or like stories of women who've been experiencing sexual concerns so that our users can find some way to relate to the characters and get more engaged with the content. So here, this character, Shalina, she has a background of like experiencing sexual concerns, and she goes through some of the examples of like doing some practices in the cognitive behavioral therapy. So that kind of gives users an example on how to go about doing the program and even modifying it to their needs. So eSense is great as it like gives that space to modify certain certain activities to fit your needs, and also is quite general and provides general information for a broader audience. So it can be personalized and has like that wide outreach as well. And next, this is an example of a between module practice. So at the end of every module, there's between module practice activities that gives the opportunity for users to practice any like content they've come across early in the modules or any skills. And this really helps them build on those skills that are helpful and that can be helpful tools to manage their sexual concerns. And yeah, and at the end of the module, we have navigators that help users navigate certain situations that might come up when they're going through the content, if they have any questions, and if they just have some things to talk about with their experience with eSense. They have navigators who can help them work through that. So here they are able to schedule meetings with their navigators. This is a weekly meeting that's about 15 to 20 minutes. Yeah. And yeah, you can find more information about eSense on our lab website. I hope the QR code works. I tried it out and it should work. So yeah, thank you so much.
That was a fantastic presentation.
Thank
I
you.
really enjoy it. What fantastic work and great graphics. It was like very engaging and direct. Yeah, it was
Thank you so
fantastic.
much.
Thank you.
Thank you.
Who, like, I'm going to ask Gabby if she's ready now or still on the train.
I would prefer to go next. I just got off the train, but I just have to cross through check-in, or at least get inside the airport.
All right.
I'm still outside.
You're still outside. So somebody else goes now first?
That would be great. That would be great.
Yeah,
Thank you.
absolutely fine. Yes. All right. Let's do care team, because we had like so let's do care team next. Dr. Alexandra Greenhill. Is that okay? All right. Beth, can you unmute her, please?
Sorry, I thought I made Alexandra a co-host, but it should be able to unmute now.
I can unmute. And absolutely always on the ready, Tibor, as you know.
I know.
Jump in. So I mean, there were so many wonderful projects presented, and it's a pleasure to talk a little bit more about you've seen care team early in Dr. Ahmed's presentation, but I wanted to cover a little bit more of the journey of what it takes. For those of you who don't know me yet, I'm Alexandra Greenhill. I'm a family physician. Before that, I was an occupational therapist. And before that, for the first 11 years of my life, I was a patient at a pediatric hospital. Starting at 11 months old, I had 27 surgeries. So I've been through the highs and lows of good things and bad things that have led me to have a lifelong passion to help people who are dealing with chronic and complex care, both as clinicians, but also as patients. And so I'll tell you a little bit more about, this is, my slides are not advancing the way they should be. But the part of what we did with care team is we wanted to build a team of people who have similar breadth and experience. And so my previous role here in BC, I was the associate CEO of the Medical Association. I worked on many committees that you were seeing today, produced the primary care networks and divisions of family practice and a number of other innovations that have benefited. And I moved over to building a company because I thought that that was a helpful way of creating the kind of tools that I wished existed, so that I can build the kind of future that my patients and my colleagues deserved. And on the team, we have Rob Atwell should be in the audience here, one co-founder, and Jeremy Smith, who was the Chief Transformational Officer for the CST project, and Mina, who is leading our efforts around how do we make this into a product that then is sold into many different areas in the practice. But what united us is that massive gap between what we read in the research papers, between what we know to be the best standard and what actually happens. And so I'm borrowing this from the UK, Mind the Gap. And the gap is the following. You have clinicians who say, I want to do better and guide the patients with all the knowledge that I have. And on the other hand, you have patients who are ready, but as Dr. Amed showed, they get a binder, they get overwhelmed, not sure where to go. And so one hand is overwhelmed, the other hand is overworked. And at the end of that, we end up with having massive costs, inefficiencies, poor access, quality issues, burnout, and all of these are worse after COVID started. So what can we do about that is, well, we sort of focused on 3 areas of need. One of them is patients repeat everything all the time. The second one is there are many people that are involved in the patient's care that are not part of your organizations. The community pharmacist, social worker, family doctor, with no idea what was said and would like to help but not sure how. And then this explosion of 220,000 healthcare apps in the App Store and different point solutions that are not connected. And we said somebody has to bridge the gap. Somebody has to start organizing this. And that's where a care team was born, between all of the hospital tools to everything that patients are using in everyday life. And so what if there's a tool that exists that allows you to put everyone on the same page, but instead of going top down, it allows the clinical team to share their solution with a patient, and everything you saw Dr. Amed present, you can click a button and start inviting others. And it could be safe and private and secure, but it can be driven by what the patient and family wants to do. And so within that, we built this over the last 5 years. It's a consortium, a partnership. Everything that people showcased about the importance of testing at every step is key. You cannot deliver something that works unless you test and test again and verify and listen to what works. You have to listen to the clinicians, but you also have to listen to the decision makers, because they have responsibilities that this just doesn't work on an individual patient level, but it works broader. So we've now helped over 10,000 patients. We have had people with Dr. Oberlander has led a fantastic project around kids with pain at the BC Children's, eating disorders from McMaster Hamilton, renal failure, heart failure, like anything having to do with complexity is a sweet spot. And then we look at who are the natural partners, and I have a number of them listed on the slide, who need to belong in that particular conversation. So the same way as I'm a GP, and I connect the number of specialists around my patient, the same way our app care team can be the digital organizer and connector. And it can be built in a way that doesn't force anyone to go through classes on how to use the product, but it's easy to use. For people who don't have access to technology, you can hit print and actually give them a printed document, or invite a digital representative to be on the app, and of course, multiple languages. That is the kind of enabler of the multiple components you need to have in place in order to empower the providers to guide people with empathy and expertise around a personalized approach to their care, whether it's before the diagnosis, or while they wait, or regular care or discharge or follow-up. There needs to be an opportunity to allow the clinical team, without any code, put in their content and deliver a better experience for the patient and the family, deliver a better experience for the clinical team, so that they can see more patients and function to the top of their license, and then deliver something for the decision makers who can see, is this program working? What are the results? Where are the gaps? So they can have, I think it was Dr. Amed who talked about a learning organization. We've dreamed of that since I started practicing over 20 years ago, and it's now a reality that we can make possible. And so we'd love to talk to more people who don't have a basis of how all of this is done, who are new to this digital world, and they don't have to do the hard work of spending a year and a half or two. We've spent the work, prepared a product, and are ready to work with the kind of clinical leaders who would like to do impact on their patients, and also do some research or quality improvement initiatives, so we can give them the data in order to show that this works, and then the ability to take that and scale it to other locations and other services and other clinical teams. And so that's a nutshell care team in 5 minutes or less. Any point of the care journey, you can use the QR code to find out more. And thank you for the opportunity to present today.
Fantastic. Thank you so much, Dr. Greenhill. That's really, really fantastic. And I also really enjoyed the invitation to the researchers that are present to think about the kind of projects that they could embark on using these type of tools. Mm-hmm. I feel sort of like I don't know if anybody's ever been on the Eurovision Song Contest. Has anybody ever seen that? It's like, if you haven't, you really have to. Anyways, Gabby, are you available?
I'm just going to go ahead and go for it. Be warned
Fantastic.
that I am on my phone. And so I'm going to hopefully be able to see the slides well. So great. Okay. So hello, everyone.
Gabby, are you seeing the proper slides or the presenter mode?
I'm
seeing
presenter mode.
It's presenter mode. This, I don't know why. There, go ahead.
It's still in presenter. It's still not full screen.
Shall I start while Beth figures that out?
Yeah.
Okay. Hello, everyone. Tibor and Beth, thank you so much for pulling this together, and thank you for your flexibility in being able to pivot like this from in-person to virtual, because I know that can really throw things off. So I'm Gabby Serafini. I am co-founder and CEO of WellTel Health. And we were actually pioneers in the field of equitable virtual care, I'll say. We're an evidence-based digital health communication platform that supports continuity of care, and we believe that no person should be left behind. So it's really exciting for me to hear that the theme this week is actually all around equity and inclusion, because I can tell you this is something that we've been fighting for the past 15 years. So congratulations to all of you for wanting to make solutions that can really reach people in need. Can I have the next slide, please? Oh, do you hear me? Or are you frozen?
Yeah, we do. It's not fixed, Beth.
Sorry, it shows it advanced for me. So let me just reshare, because
thank you.
I don't know what.
So I can tell you that we were the first program in the world to use health text messaging with patients. And we started by talking to patients on the ground in the early 2000s in the face of the HIV epidemic in Africa. So really, we kind of spun out of academia. So now we can talk a little bit about the problem. And I think everybody's highlighted this already. The healthcare system is incredibly fragmented, and it's really difficult for patients. There's no actual convenient way for patients to communicate with their healthcare providers. And the result of that, lack of access and poor communication, results in poor health outcomes, burnout for the providers, and increased costs to the system. So using WellTel, because it connects patients to their known healthcare providers through the use of their mobile phones in a very simple way, by leveraging the use first of two-way SMS text messaging, but of course with the ability to escalate to other modes of care. But we've been very careful to be inclusive and ensure that we maximize the reach of our solution. So by using WellTel, the providers can communicate more efficiently. There's early detection of warning signs of what's going on with patients in between those visits, which allows more timely access to care and services. Next slide, please. So the problem, we've been talking about this all day, it's inequitable access for about 30% of Canadians. So you can see the distribution on the right there. We have made sure that our solution provides equitable reach, but we serve urban populations as well, and it can get quite high tech. But at the end of the day, we want to make sure we meet people where they're at. So we allow proxy registration, shared phone use, the ability to use SMS, meaning that a patient does not need a smartphone and does not need to download an app. Next slide, please. So further to this problem is the actual, this is just highlighting those that are marginalized, those that aren't. So those that have choice and access, they're already using all the digital tools. They're tracking their steps. They've got a Fitbit. They can organize their own appointments. They're quite savvy at being virtual with their physicians. And then we have the 30% on the other side who lack access. And so mainly what they're doing is using emergency room services. And we're seeing poor health outcomes, and they're falling through the cracks. Next slide, please. So here's just some numbers, right? Cost of chronic disease in Canada. The reason I'm talking about chronic disease, and all of you we've talked about diabetes, we've talked about cancer, mental health. So chronic disease is something that if there isn't intervention in between those visits, this is where people can really fall through the cracks. So a $200 billion cost of not caring for chronic disease, and 125,000 potentially preventable deaths. So what are the two top ranking strategies to improve patient retention and health outcomes for chronic disease? It's actually communication and inter-visit outreach, and this is exactly what we have focused on. Next slide, please. I love this quote. I also have a daughter who graduated in theater, but communication is absolutely critical in the healthcare journey, and it has to be convenient and it has to be accessible. Next slide, please. So this is just giving you an idea of how the WellTel solution works. So the platform itself that providers use is device agnostic, so they log in from any device. The patients can use any type of cell phone, so they're enrolled using their cell phone number. We've done a lot of research. We have about 75 leading publications on the efficacy of WellTel, and our research has been cited 4,000 times. We still maintain a strong academic partnership with UBC, and we use an automated model of support, automated check-in model. So we're disease agnostic. So we just simply ask a patient, how are you? They report in on any health issue of concern. Because like the person from Thrive said earlier, you might have diabetes, but you also may have mental health issues. You may also be pregnant. So we look at the person as a whole being, and we just communicate with that person. So device agnostic, multilingual, simple check-in message. The research shows that people are more likely to self-reflect and report in on any health issue of concern. The platform that the care providers use meets all privacy and security standards. And of course, it collects all the actions that you need for an integrated virtual care experience, including secure photo and document exchange, beginning with SMS, leveraging to voice and video when needed, as well as a patient portal for patient recorded outcome measures, the ability to track metrics, and so on. Next slide. Now, give me 1 second here. I'm about to go through the the check-in. They're going to scan my code, so I just have to go off the screen. 2 seconds. Okay, no, actually somebody did it for me. Okay, so I want to talk just a tiny bit about the flagship WellTel proof of concept we've done at BC Children's Hospital. This was with the Department of Pediatric Cardiology. So led by Dr. Catherine Armstrong, many of you I'm sure know Catherine, launched in 2018. So they're currently supporting over 1,000 patients and their families across BC. It's the first pediatric program in Canada that we know of that has actually published to show improved health outcomes using a digital health communication tool. And we have had incredible success with this project, everything from not only outcomes being improved in the province, avoiding unnecessary visits to the ER, avoiding unnecessary appointment visits when not needed, but also they've managed to actually triage families into appropriate care while they've been traveling overseas. So I've got a newsletter, I can share that with you later. Next slide, please. So these are the impacts that we're seeing with our solution. So it's patient-centered, improves patient engagement. We have AI-assisted open SMS text and informative analytics. So the system can actually triage responses into categories based on need for follow-up. Providers are spending less time on follow-ups and patient management duties. So of course that increases their capacity and allows them to treat more patients, but it also drives cost savings and reportedly reduces burnout. Next slide, please. So these are just some of our competitive advantages. So we have universal accessibility. We're currently deployed in 10 countries, serving hundreds of thousands of patients and thousands of care providers using the system. You may know that we scaled to the entire country of Rwanda, and we are actually in the center of their digital health ecosystem as their patient follow-up and engagement tool for the entire healthcare system. And Rwanda is actually a leader in the world. They were ranked number 6 for COVID response, compared to Canada ranked number 53. So we focus on open language communication in any language, and then our algorithms are built on 15 years of multilingual conversational data sets, which actually improves the reliability of the algorithms, and this helps health systems to allocate resources more appropriately. I think I've said the rest. Connecting patients to their known healthcare provider builds a stronger relationship. It builds trust. It improves outcomes. And we've seen in the literature actually that the only thing that really does improve health outcomes is a relationship over time between a patient and a known healthcare provider. A lot of the other digital systems that we introduced a decade ago for informatics and for collecting data have not been shown to improve outcomes. It's definitely the relationship, and that's what we support, a relationship-based model of care. Next slide, please. I think many of you know Dr. Richard Lester. He's our founder and product lead. He's an infectious disease physician at BGH. The others, it's kind of irrelevant. And that's all. Thank you so much for having me today. I'm sorry for this slight rush.
This has been fantastic. It's like our reporter from the actual fantastic, like presenting while in the airport.
Well,
this is
Tibor, thank you for that. I just want to share with you all that I actually just returned from Rwanda because they expanded our platform into their Ebola response. So I've just come from 2 weeks of working with the Ebola team, and it's really exciting to be part of a mission-driven company that's really determined to promote equity and inclusion. And thank you everyone for your commitment to that.
Oh, fantastic talk. Thank you very much. Next up, and in the interest of time, we're going to go straight through to HIMSS BC for next present. Pardon me?
Just give me a second and I will get
and
that.
that's Maury Matsusuka and Rachel Barker.
And let me make that so Rachel can. Do you have your slides handy, Maury? Do you want to share your own slides or do you want me to do it?
Yeah, I can do that if that's easier for you. No problem.
Sure, go right ahead.
Hard to follow up on such an amazing presentation.
Yes,
I've never seen, but kudos, super kudos. There's so many amazing presenters here and so many wonderful projects doing great things. So I have Rachel Barker here with me today, who's the president of HIMSS BC. Maybe I'll ask you to kick it off. I'll also introduce myself. My name is Maury Matsusaka. In my day job, I work as a project manager under the eHealth projects team here at PHSA. I'm also the programs director for HIMSS BC. So over to you, Rachel.
Maury, do you want me to share the slides?
Oh, sure.
Okay. We're going to do the dance. Hang on 1 second.
Just want to say thank you to all of you for pivoting and making this work on such short notice. And I appreciate that.
It's okay, I've got it.
Very nimble in this presentation.
No problem.
All right, perfect. So thanks, Maury. So who or what is a HIMSS? And why are you here? Why are we talking about this? So HIMSS is a mission-driven nonprofit. They have chapters all over the world, a global advisor and a thought leader supporting the transformation of the health ecosystem through information and technology. So the way that this works is there are HIMSS chapters, 3 of them in Canada and all over the world. And it's a really local focused presence with just people who are really passionate about breaking down barriers to innovation in healthcare and the potential of technology to have a positive impact in health. As volunteer board and volunteers helping out the HIMSS mission. So next slide, please. Which is the vision of realizing the full health potential of every human everywhere and the global HIMSS mission of reforming the global health ecosystem through the power of information and technology. And for what our chapter does specifically in BC, that means promoting the understanding for the efficient exchange and effective utilization of information and information technologies within BC's healthcare environment specifically. So what this looks like kind of in practice, and Maury is going to go into some detail on the very specific things that we've done in the past and some very cool things we have coming up this year for you, is that different chapters will get involved in things like events, consulting, networking, or facilitating networking around the community, health policy, research, education, analytics, and sort of sharing news. So our chapter specifically is really involved, especially in events, networking, and education. As you'll see very shortly here, we have a nice mix in our chapter board of private and public. To Maureen's point, a lot of us have day jobs, often sometimes within the health authorities, sometimes within private, sort of bringing ideas in from all over. And then if you flip to the next slide, we also have amazing partners throughout all pieces of the system who help us sort of bring this journey to life. So we're really excited to be here for Digital Health Week with Provincial Health Services Authority, which for some of us is also our day job, BC Children's Hospital, and Women's Health Research Institute. And then we have some phenomenal sponsors in the private sector. You heard from Thrive a few minutes ago, so you're really familiar with what they're doing, who help us bring this mission to life. Because if you've ever thrown an event, you know that conference venues are very, 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 very expensive, and especially if you want the food to be good for people, which we always do. So we're really grateful to have the support of Accenture, AWS, Cerner, CGI, Clearview Group, Meditech, SAS, TIMA, Teladoc Health, TELUS Health, and Thrive Health. And it also gives us some really cool access to, physicians working on projects with them in their network. Sometimes, worldwide information that they have both through their work as a public sector entity and through sort of the HIMSS network. So next slide, please. And then one other sort of concept we have in terms of our chapter and what we do, our membership is all kinds of members. So we have members that come from private sector that are sort of independent members or chapter only members. We have student members, but one thing we wanted to highlight for this audience specifically is we have a concept called organizational affiliate members. And why you should care about this is you might be able to be a member completely for free and not even know it. So organizational affiliates are organizations that are on board with this HIMSS mission. They see the value of digital health. They want to make an impact. They want to share education and break down silos and connect with others in the community. So if you're a member of First Nations Health Authority, if you work for Fraser Health, Interior Health, PHSA, or Vancouver Coastal, and for PHSA, it includes all of those subdomains. So if you're BC Women's and Children's, if you're BC CDC, we got you, it'll work. We got it fixed. If your BCH and a subdomain isn't working, email us and we'll get it fixed. Still working on that one sometimes. You get a free full regular HIMSS membership. So that's not only chapter membership, which is networking with us and our events and our conference and that sort of thing. It's actually access to the full HIMSS Global Library and resources on the website. So it's a $200 value, and it's included in your organization that's just sort of opted in and paid a flat fee. And if you have an email address for one of these institutions, you can sign up. It takes about 5 minutes and you get a free full HIMSS membership. And Maury, what does that get them? Oh, mute.
You're on mute.
We talked about networking, and so next week we actually have our annual general meeting. So certainly it's a great time to sign up because we'll also have drinks, food, and opportunities to connect with various folks from across the healthcare sector. So that's happening next week at St. Regis Bar and Grill downtown. Many of us, it may be one of the first or a few events to actually get in person, but there is also a virtual component. So if you just want to log in, learn more about what we have in store for the upcoming year, certainly welcome to do that as well. But we'd love to see you in person. So as programs chair, we always try to bring some of the most relevant and exciting topics to bear. Most recently, yesterday, we were very pleased to bring together some of the folks from the Immunization BC team, PIRS, and so forth to talk about how they ramped up the immunization and vaccine rollout in response to the pandemic. So we really always want to be bringing those exciting topics to light. And on the slide here is just a couple of the events that we've brought to our members. We're always looking for opportunities to highlight exciting projects like many of the ones that we've heard from today. So certainly reach out and get in touch. One of the other things that we also end up doing, first time that we're going to be doing it in 2 years due to the pandemic, but we're aiming to put together a spring conference this year in person. So here's again just a couple of the speakers and topics that we have had in conferences past. And this is a really great opportunity just to hopefully bring in some exciting speakers, really speaking about the forefront and the trends happening in digital health, not only here in BC, but hopefully globally. So very much looking forward to bringing that back to you in person this spring. And then last but not least, we are actually also launching our HIMSS membership or mentorship program. So looking for digital health, informatics leaders in the healthcare space who would like to be paired with a junior or a member who is actually looking to shift in their career. So we have an exciting mentorship program that we've just recently launched, and we are looking for members to apply both for mentorship and mentees. And that's about it. So certainly excited at the prospect and the opportunity to connect with all of you today. Beth, thank you so much for the opportunity and invitation to join. Here's a couple of ways to get in touch with us, and certainly let us know if you want to join as an organizational affiliate member. We're more than excited to have you. Thanks so much.
And it really does only take 5 minutes to register, because I just did while you were speaking. Your PHSA, it's super easy.
But aren't we already a member? Do we still need to register?
You still have to register.
You still need to register. All right, so I will.
Eligible for
You see me at the St. Regis. Yes, that sounds great.
Fantastic.
Yeah.
Fantastic. And if you look, if you look behind you, there's courtesy of HIMSS there. We are now getting cookies delivered by drone. Okay, we're not there yet, but we will be next time.
I love that idea. I'll take a note for the next event. Fantastic. Thanks so much, everyone.
Thank you. So next up is the only person that I know that probably drinks more coffee or just naturally has more energy than I have, and that's Carrie Gibson from BCCHR. Is she here? I guess not. Oh yeah, she is. Just need to get unmuted. Yes. You're unmuted. Yeah, we can hear you.
Fantastic. Sorry, I had to dial in on my phone. For some reason, my computer just keeps on knocking me off to do updates that I but was it rather inconvenient. But thanks, Tibor and Beth, for having me here. It's been really exciting to hear about all of the Made in BC initiatives that are happening. I'm VP of Strategic Partnerships for BCCHR. It is a New York-based health tech company, although I am grateful to be living and working on the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh. Thanks, Alexandria. Nations. It in this beautiful country of ours. BCCHR specializes in remote diagnostic health technologies. We provide a clinical diagnostic experience wherever the patient is. We have both proprietary software and hardware, and built a service around that, tech-enabled service. We're currently working in New York, New Jersey, Florida, and we began about 2 months into the Ukrainian invasion. We began operating, doing crisis relief in the Ukraine in partnership with the Ministry of Health, as well as several NGOs from across the world. Our remote physicians are actually in Israel. They are with the Israeli Medical Mission. And our OCCs, our on-site care coordinators who have been trained to use the technology, are with the Ukrainian Medical Mission, the boots on the ground, if you will. And just this morning, we were serving and engaging with refugees, displaced populations in liberated territories, and wherever they were congregating. This morning was church. We had a bit of a pop-up clinic in a local church. In the US, we work primarily with marginalized communities. We are covered by half a dozen different payers, including Medicare and Medicaid, as well as we work intimately with social service organizations, community organizations. We said basically wherever there's populations, patient populations that are in need, that aren't getting the care that, the preventative medical care that is required. And to tell you a bit about how Zippy Care works, let's just say that grandma's not feeling so hot. And perhaps grandma is, tech savvy like my parents are, and she can use the app, which is, basically like your Uber for healthcare. But, what was it, if she isn't, we don't want to put the onus of tech knowledge on the patient. So she can just give us a call, or, her neighbor, whomever, can just give us a call, and we will dispatch an OC care coordinator with the proprietary hardware. Now, the hardware, the Zippy kit, is essentially a hospital in a box, a hospital in a suitcase. And the OCC takes that technology to the patient, sets it up, talks grandma through what's going to happen, does a social environmental assessment, makes grandma comfortable, and then dials in the physician remotely. And so the OCC then is an extension of the physician's hands. The physician instructs which tools to use. Do we need to run an EKG on grandma? Do we need to do any lab work? We have partnerships with LabQ, so that we get, almost instantaneous results. And then, they were able to provide a diagnosis on the spot. And if grandma needs some support, we actually have a care management program that we can enroll her in. And then we can basically build a support team around her, bring in specialists, bring in social workers. Right now we're building a bit of a food RX arm, to enable these marginalized populations to benefit from increased nutrition. And so we are, my legal team has assured me that we will be able to be operational in Canada in 2023, in which we are very much looking forward to, particularly engaging with remote communities.
And are you looking for researchers to join you on use case studies for that endeavor?
Absolutely, absolutely. We welcome all partnerships. We couldn't work without the amazing partners we have in the US and the Ukraine and so forth. And we're looking to build the same. Do some research in partnership with local organizations, and to showcase how Zippy Care can assist, the very stressed healthcare system locally. For instance, apparently there's a backlog of 16,000 patients requiring EKGs. I mean, we can knock those out, and they don't even have to leave their homes.
And yes, you can see how that would be incredibly useful. In the interest of time, I'm going to stop you here, Carrie. I'm going to go on without any further ado to entrepreneurship at UBC. Jonathan Jafari, please take it away.
Thank you. It says my screen sharing is paused.
Let's unpause you.
Please.
Do you want to just stop and then re-share? I'm not sure what. We've had a lot of screen sharing issues today.
There we go.
There. We can see you.
Excellent. All right. Thank you so much for allowing me to present to you today. Some fantastic presentations. My name is John Jafari. I am the lead entrepreneur in residence for the Human Health Venture Studio at Entrepreneurship UBC, and it's great to be here. So we are very much early, and we hope to, engage and help develop fantastic companies like CareBase, Thrive Health, etc. We also look to provide entrepreneurial educational experience to the students, undergraduates, graduates, postdocs, and giving them sort of opportunities to become entrepreneurial thinkers. We have a number of different ventures where students have started one venture, have failed, come back and started another, and been much more successful. And one thing that's unique about us is that we don't really care that much about the monetary return. We care very much about the societal benefit, as well as making a business sustainable. And we do this by inspiring, providing educational opportunities, and building companies. And so how do we support entrepreneurs or prospective entrepreneurs? So business model validation, mentoring, it can be anything from very light mentoring to very deep mentoring with an assigned entrepreneur in residence. We do have space, and we have a very active investor community. We can provide introductions and help you write your business case and pitch decks, et cetera, to be ready for investment. So this is a busy slide, but I'll go through it really quickly. So community engagement, such as events like today, we present to a number of different groups around town and also across the country. And we really focus on, so the Entrepreneurial Explorer program, that's for very early education. It's sort of an online Entrepreneurial Explorer 6-module learning modules. It allows you to sort of understand how entrepreneurism works and sort of where to go next. It's open to everybody. And then we have our very programmatic Lab to Launch and Core, which is part of Venture Founder. And so that's where a postdoc, student, professor, PI comes in and does a very in-depth business development sort of course. It's 12 weeks. Customer discovery, and by the end you should be ready to be pitching to angel investors, VCs, etc. And then we can graduate you into something we call Hatch Venture Builder, which provides we can provide some very limited seed funding, but also some space and some builder expertise. And then in terms of the studios, which I'll get into next, we have 3 different studios, and this provides very detailed, specific health for all the ventures, depending on where you're looking at. So we have a climate venture studio led by Dr. Shannon Bard, and she works with various climate ventures. Myself, human health venture studio. So my background is mostly in biotech and pharma, but I've been really really helping to support some of the digital health initiatives that we have, and that's very much an area of expansion for entrepreneurship UVC. And then we have a social venture studio led by Angela Hamilton. And so a lot of the ventures within the healthcare studio are also part of the social venture fabric ecosystem. So we have done some joint events, and also can provide sort of some of the impact metrics that'll help you get funding from different types of venture sources. So in terms of digital health, some of these you may have heard of. Smart Mom, Patty Jensen, she must be hopefully very familiar to you. It's a text-based service for new parents. Flutter Care is another app which is for perinatal care. And then we have, different types of digital health ventures, such as Raven, which is a AI viewing of CT images, etc. Beam AI is to monitor stress, which is a pretty interesting venture. And then Mona, which is Ziba Khan, some of you might know her as well. And she is looking at polycystic ovarian disorders. And then My Circle is a mental health app. And so these are the type of ventures that we're currently working with. And I know that there's some folks that are here on this call that we've engaged with, and we hope to bring you into our sort of square of companies, and move you forward into getting funding, sustainability, and impact.
Fantastic. And Genexus is a pharmacogenomics venture.
Excellent. I forgot to mention. So if you have any questions, please reach out. I don't have a QR code. I feel a bit left out, but you can reach us just by searching Entrepreneurship UBC. And we hope to have additional events in the future with you, hopefully in person. Great to meet you all. Thank you.
Thank you. John Jafari, thank you very much. That was a great presentation, and amazing to see that these types of resources are available for researchers like embarking on these sort of larger digital health projects that then eventually end up in a product or a company as they scale. So
I should mention that we don't charge anything. We're free.
Oh, that's amazing. Yeah. So as a Dutch person, I like that very, very much. That's great. That's fantastic. Just opening up the floor if there are any questions for any of the companies from the audience. I think what we try to do here is to make connections, show what people have, and how we can work together to make partnerships so we can get our endeavors off the ground. And we're hopelessly over time, so I will now sort of like bid you farewell.
One quick thing is for anyone who is looking to establish partnerships. If you've heard something you're really interested in today, you can always reach out to Tibor or I at the Research Institute, and we can help facilitate connections. That's part of our roles. And so I'll give it back to Tibor for the final remark, but just thanks again from me for everyone for sticking in with this. And hopefully we will have an opportunity to replan the in-person event in the new year.
And you can find us at DHR, Digital Health Research, at BCCHR.ca. So just shoot us an email, and if your idea is sort of like that one company that was talking about that thing, who is that again? Can you put me in contact? We can. So, and thank you everybody who participated, and thank you everybody who stayed till the final bits here. Thank you very much. I very much enjoyed it. It was great. Thank you everybody. Have a fantastic rest of your evening. Bye.
Thank you.
Thank you.